I would like to show you the project we've done in development of Czech national stroke guidelines. I have no conflict of interest, I think. So we've done we started developing the Czech guidelines on stroke and why we did what we did. Stroke is very highly prevalent disease with very severe consequences. So back to 1990s, looking at the years of life lost, it was always, or used to be always, communicable diseases globally. It has changed in the last 20 years, so now we've got non-communicable diseases as the most common cause of years life lost, and it's ischemic heart disease and cerebral vascular diseases, with the second leading cause is still globally it's a stroke with ischemic diseases. So why stroke? We stroke physicians, we are the plumbers of neurology, they call us, because we are just, if there's any blockage, we just need to clear it up and that's it. And it's very easy to do it. If you have, you need to have 24/7 service and you need to be emergency stroke physician working fast and running. Otherwise, it's very simple. Both males and females are affected, and it's on the right side or on the left side coming with the clinical symptoms. Then you do scan, brain imaging. There would be big black or big white hole, which is an ischemic stroke or hemorrhagic stroke. So it's on the left or right, black or white, and then you would have a clot or blood. That's it. This is the stroke medicine. So 88% strokes are caused by a clot, which we call it ischemic strokes, 12% hemorrhagic strokes. So we focus in our guidelines on ischemic strokes first. So how you can manage ischemic strokes? The colors are quite strange. There's a lot of strategies how you can manage ischemic strokes. Before it happens, you've got primary prevention. Once it's happening, you can recanalize. This is the point where you need the plumbers, and you do some neuroprotection with quite unsure strategies. And after it happened, you would need to do secondary prevention, manage the complications, and something we call neuro repair. So ischemic stroke. Majority of strokes, ischemic strokes, are caused by cardioembolism. So the clot is coming from somewhere in the heart. And the most prevalent cardioembolic cause is the atrial fibrillation, which is the most common arrhythmia. So the clot would go from the heart, cause the blockage, then call the plumber. Atrial fibrillation and stroke, if these two are going together, it causes huge increase in mortality, morbidity, severe consequences. We've got lots of evidence. So this is why we need to prevent, because this is preventable damage. Even primary or secondary prevention. And we've got now different strategies. So we use anticoagulants to prevent ischemic strokes caused by cardioembolism in patients with atrial fibrillation or atrial flutter. We got direct oral anticoagulants, which are quite new drugs, established 25-30 years ago, so they are not new anymore, but still. Or we got the old-fashioned one, which is warfarin, which still works, and we still use it in some certain indications. So we've chosen for the first pilot guidelines, we've chosen the highly prevalent disease with severe consequences, which is stroke, ischemic stroke, and cardioembolic, so the highly prevalent. And because based on our epidemiological and other data we've analyzed, we've realized we don't use the anticoagulants and the primary and secondary preventive strategies as we should. This is what we want to change. This is the project, the Czech National Guideline Development Program, which started this year. We are celebrating 100 years of independence. This is the picture you've seen in the morning. So lots of guidelines with no systematic approach, which we really needed. So this is why we've established the program. We've got 6 pilot topics, including 1 in stroke neurology. So what we did, started planning, development, dissemination, and so on. So basic steps. We had a group of authors. The guarantor, it's very important, was the president of the Czech Neurological Society. We got authors, stroke physicians, and we got a group of methodologists, which are doctors. Then we got a multidisciplinary panel, which is sort of reviewing our steps from the outside. So we got president of the Czech Cardiological Society, with clinical pharmacologist, and we got GP, internal emergency medicine doctor, and non-healthcare professionals who is a researcher, so who is able to see what we are doing in terms of research. We've determined some clinical questions, focusing on the patients with cardioembolic stroke, anticoagulation, no treatment, some outcomes, direct oral anticoagulants versus warfarin, and warfarin versus antiplatelets. Search, we've done the usual search, including the World Stroke Organization, European Stroke Organization, and Australian Stroke Foundation. And the question was whether there are any guidelines which are already developed on the topic, and whether they are up to date and developed using great methodology. Fortunately, we found the Australian Stroke Foundation guideline, which was done last year using the great methodology. 1 minute? Good. So we took it. We found it's the high quality guidelines in terms of methodology. So then the question was adoption or adaptation. We've realized we need some more implementation strategies. We need to tailor it for the Czech settings. So we decided to go for adaptation using the adaptee, which is there, and this is the final result. We've almost adopted the main evidence-based recommendations. So this is the first pilot version, which was agreed, and it's about to be disseminated. So next we'll finish the other secondary prevention topics, and then there's lots of space in the playground we can play with. Thank you.
I was just interested in the amount of adaptation that you had to do from the other earlier guidelines. Sort of what were the key areas that you had to adapt?
Yeah, so we've decided to not to change the main strong recommendations based on the grade. So they had different levels of recommendations. So they had the strong grade. It was very clear. So we decided not to touch them at all. And then they had some consensus based or expert opinion guidelines or recommendations, and we've decided to change them. We've done the consensus, multi-stage consensus, using sort of Delphi methods, because we wanted to go a little bit deeper in terms of complications of anticoagulation. So we just decided to adopt some guidelines from the European it's Heart Rhythm Association. They've got guidelines on atrial fibrillation and anticoagulants, so we were just adding it on the, and so the initial guide, the original guideline, the original recommendations from the European Association is evidence based, and we've just made sort of consensus based, so we downgraded them a little bit, but it's still valid. So.
That's interesting.
General question. When you're adapting a guideline and you face some recommendation that culturally is not acceptable in your culture. Thank you. if there is some recommendation in original guidelines that culturally is not acceptable for in your own region, how do you manage those kind of recommendation? You just ignore, or just adding some something to those recommendations?
So generally speaking, this concrete one, it's very easy, because warfarin is warfarin. Even in Australia, here aspirin is aspirin. It's very, very similar. So this is why we didn't need to touch the recommendations. But if something like basically adding the European ones based on the consensus, so every single step needs to be documented. So we had a lot of appendices documented why we decided to put these recommendations on the top of the others, and those consensus based on. So if we have something, if we had potentially something cultural which we wouldn't adopt or adapt, we would just document it in the guideline. This is what we've probably, it would be consensus based. So based on the consensus, we didn't adopt or adapt these particular recommendations, because once we decided to adopt or adapt the whole guideline, so we would just take it. But if we can't adapt something which is not culturally relevant or impossible to adapt, so we would just document it. These particular one we wouldn't. But I'm just thinking about some example what we wouldn't.
It's got about 12 seconds.
12 seconds.
Not a bit precise.